any questions throughout the presentation, please send them to us via the Q&A function in Zoom, and we'll be sure to have them answered. Thanks again for joining us, and Dr. Barkman, please take it away.
Okay, can you guys hear me?
Yes, we can hear you, Dr. Bartman.
Beautiful, thank you. Welcome everybody. What an interesting time to be talking about routine stuff. But it's a little interesting because our group is starting to see some routine patients now, and we're excited about trying to get back to a little bit of normal. I'm going to share my screen here, and in the presentation walk through a few things that I think are pertinent to history taking. We're going to dig into some examples, what's good, what's bad, what works, what doesn't. This is admittedly an extremely dry topic, and I wish that you know, someday I'm gonna move up the ranks here, and I know I'm gonna get some good topic like, you know, show surgical videos or crazy cases, but we're going to stick with this, and I've tried to make it at least somewhat interesting. Because believe it or not, history taking and pupillary exam, while, you know, most people groan about this is the boring stuff, and it can be interesting, and it's really important. So I'm going to start moving through this, and please stop us with questions. Okay, so I don't have to explain, I'm sure, but the patient history is very important. And there's a variety of components to obtaining history from patients. The first thing is the chief complaint. We're gonna walk through each of these things, but the chief complaint is why the patient came into the office. It is their problem. Sometimes there's one, sometimes there are multiple, and sometimes there's seemingly none. But I say seemingly because if they're showing up to the office and it is not for a routine vision exam, if it's actually a medical exam, there needs to be something, otherwise they wouldn't have likely come. History of present illness explores a little bit more about the chief complaint. Why are they here, and what events or circumstances led to their problem? A review of systems makes sure we don't miss anything. Other things related to the eye and systemic health are reviewed in review of systems. Past medical history is a snapshot of all things in their medical history that might be contributory or otherwise in the patient's presentation. Past ocular history is just the same, except for the eyes. And then family history and social history add some context, whether or not this is something that could be genetically passed or obtained through social interactions. Okay, so the chief complaint. This is the reason, and it's the patient's stated reason for why they're here. When there are multiple, we really want to take the primary one, and we want to isolate that, and that helps us as physicians and eye care providers to really stratify what's important and what to hone in on. And that's why the chief complaint is so important. I do recommend that staff put in direct quotes from patients. That works really well. That way there's no interpretation change or translation that happens from the patient to the paper or the EHR. It can go directly in as the quote from the patient. So let's cover some of these. Here's some good examples of chief complaints. Vision in my left eye is cloudy. I have a cataract in my right eye. My mother had glaucoma and my pressures are high. My left eye is stinging and burning. Or fill in the blank, anything related to their eye and some sort of problem, okay? So these are good. Here are some bad ones, right? Dr. X said I have cataracts. That's not a chief complaint. We can't actually use that as a chief complaint when we bill medical eye exams. IOP check, also not a chief complaint. A chief complaint for somebody coming in for an IOP check would be something like, I have glaucoma and I'm in need of a pressure check. My eye has been feeling irritated from the drops. Something like that could be a good chief complaint for an IOP check. Also, routine eye exam, Also not something that usually works well for the chief complaint. Here's some ugly. I'm not sure why I'm here. That's the worst one that we can get. In this situation, here's my recommendation, because it's not impossible that this would happen to you. Ask the patient some directed questions about their eyes. If the open-ended, tell me about why you're here doesn't work. You say, how is your vision these days? Do you have any trouble with your eyes or problems throughout the course of the day? And then you write down the answer to those questions. I'm going to pause here before I move on to the HPI and see if Jamie has any questions that I can answer now.
So far, we're no questions.
Oh, excellent. That either means I'm doing a really good or really bad job.
I think really good.
Great. Okay, so let's dig into the HPI, because this is the meat and potatoes about why somebody came in, right? This is room to expand on the chief complaint. Where does the problem happen? This can be the right or left eye. Quality, what does it feel or look like? Severity, how bad is it? Duration and frequency, to give you some information about the timing, how long it lasts and how frequent it happens. The context helps us identify, and sometimes this is associated symptoms, etc. In what situations do you notice it? Modifying factors, what seems to make it better or worse, and then associated signs and symptoms. What else do you notice when you have that problem that you're telling me you have? Okay, in this field, we want to get as much information as we can get. In general, when we bill medical eye exams, we want at least 4 of those. And 4 is a good number to just have in the top of your head, because even if we're not going to bill a full medical exam, we still want to know as much as we can, because that helps us understand the patient's problems. And the patient often volunteers much of this information. And if you listen, a lot of times the patient will tell you exactly what's going on. So let's do an example. I'm going to read this word for word and think about some of these examples that I put out, or those characteristics of the HPI as I'm reading it. Well, I'm here because my eye doctor said I have a cornea problem in my right eye, something about swelling. He said that's why I don't see as well as I used to. I notice it most of the time at night when headlights get streaky and blurry and I can't see street signs. I used to only notice it sometimes, but now it's almost nightly. And it's gotten pretty bad. I almost wrecked the other day. I've been using this gel he gave me at night before bed that seems to help, but it's still a problem. It doesn't hurt or anything, but it makes it hard to read sometimes. Okay, and this could all be following the question, what brings you in today, right? How many of the elements can we pull out of this paragraph? Let's look at it. We've got location. He said the right cornea. The quality is blurry and streaky lights. The severity is pretty bad, right? Didn't give us any information on duration, but frequency happens almost nightly. Context happens, it happens while driving and reading street signs. Modifying factors say it's using a gel at night and it helps at least to some degree. And there's no additional associated signs or symptoms given. So right there in that short paragraph, the patient is giving us plenty of the information that we want to include in the HPI. I'll pause there as well, Jamie, to see if there's any additional questions about HPI.
We do have one question. Going back to if we would have a patient coming in for an IOP check and the chief complaint, if the patient has no complaints, the drops are doing well for the patient literally has no complaint with vision or eye comfort, would putting in patient has glaucoma, IOP check, still not be sufficient? Or how can I phrase this differently?
You could also add, that's a great question. You could also add here for monitoring. There are certain conditions like glaucoma that require monitoring even in asymptomatic cases. We just want to make sure we are documenting it appropriately. Most of the time, we're also not billing IOP checks on a high level that's going to require significant in-depth history. And so that one can be a little bit fluid, but I would always write a little bit more than the IOP check. I would flush it out a little bit more to add some substance to it and make sure that there are no additional problems that you can address. But that's a great question. I would include here for periodic monitoring of glaucoma. Okay, I'm going to move on to, is that correct? Is that,
Yep.
is that
All the questions answered thus far.
great? So the review of systems, this covers all of the other medical problems. This is on this screen, you can see an example of the review of systems that we use under each category of the systemic system. We've got different problems that we want to just ask about, things like asthma, shortness of breath, heartburn, abdominal pain. This is something that the patient actually fills out for us in the waiting room. Now, when we transition to doing things more virtually and collecting data over the phone, we may be going through this with patients. But for the time being, or at least preceding coronavirus, we were doing this in our lobby. This is allowing us to collect all additional health information. We also care about medications. There are medications that we care more about, things like eye medications, insulin, some medications that affect how we approach cataract surgery, like Flomax or tamsulosin. Opiate pain medications can cause pupillary differences. And so we want to just make sure that we're at least getting this information to the doctors so we can understand how their medications might be playing into their current problem. And then also on this sheet, family and social history, right? Why do we care about this? Think about ways that social history could possibly be related to eye health. Well, we know that one of the most common things that we write for social history, and we ask overtly there, is, do you smoke? And if yes, how much? Because smoking can impact things like cataracts and other problems related to the eye. And so we want to make sure that we're getting this information. It also may help us delineate the risk of undergoing certain types of anesthesia. While most of the anesthesia we use in eye surgery is topical, there may be some cases that we really want to know better some of their other health issues. And then their family history. So you may know of some eye conditions that can be inherited, things like Fuchs corneal dystrophy, or even cataracts, macular degeneration. These are things that can be inherited. And it's nice to know if the patient has a family history of this before we even see them. And then to finish up, I believe, on some of this extra history info, we want to collect things like drug allergies, because there are a variety of drugs that we use that may, in ophthalmology, that may be related to drugs that they're allergic to. Sulfa is a common one. Sulfa is in a few of the medications that we use for antibiotics or glaucoma medications. That being said, there are also a ton of glaucoma medications that patients can say they are allergic to, but really they just made their eye a bit red. And so it's really important to help us distinguish between true allergy, which I usually go over with patients, or things that are more of just a side effect, like the glaucoma drop Ropressa causes redness to the eyes, and they may say, I have an allergy to Ropressa because it made my eyes red. That's not actually a true allergy. And it's important to find out what happens when a patient is exposed to what they say is an allergy to them. And that's one of the reasons. So I'll pause here as well to find out if we have any questions.
We do. We have a few really good ones. So question on the doxazosine.
Yeah.
What are the complications?
Good question. That is an alpha blocker that is related to Flomax. Those are just a couple of the medications that we as cataract surgeons pay attention to when we are bringing a patient to the operating room. It may mean their pupil behaves differently during the course of their cataract surgery. So less important in an optometric situation, but certainly something that I circle every time I see it on a patient's medication list. But excellent question. What else?
Do you feel that dosage is important in medication documentation?
That's really a really good question. Most of the time in what we do, I don't think it is as important. However, if a patient comes in with their list of medications and dosages, I think it's really important if you take a copy or put it into the system. The one reason off the top of my head that I can think of that it would be important would be in things like diabetes, because the more insulin somebody is on, usually the harder it is for them to control, and maybe they're at higher risk of problems related to that. But from a provider's perspective, just giving you what I look at, most of the time I'm not looking at the dose. However, that's for systemic medications. For ocular medications, 100%. How many times a day they're on a drop would constitute the dosage, or the dosage of, say, an antiviral pill that your doctor had put somebody on for viral keratitis. These would be really, really important to document. So certainly anything ocular related, ocular medications, we'd certainly want the dosage in. But for the other stuff, it is not quite as important or critical to get the dosage just right.
Awesome. So we have two questions regarding the review of systems, and I'm going to read them both to you as I think you'll be able to answer them together.
Okay.
If that works. So the first of the two is, do you always make sure the review of systems and past medical history match at each visit? And then the second being, are the review of systems only for what patients are suffering from today? For example, if we have been seeing a patient for 10 years at our clinic and they have hypertension without any changes, do we remove hypertension from review of systems and put into past medical history?
The second question I'll answer first is yes. Most of the time, review of systems is to flush out anything that could be related to the active problem. However, it's up to an individual provider how they want to see that information. Personally, I would rather see chronic medical conditions put in past medical history rather than the review of systems, and use review of systems to trigger additional questions or management strategies that I might have. And I believe the first question was, sorry, Jamie, I completely forgot what it was.
No, you're good. Do you always make sure the review of systems and past medical history match at each visit?
I personally don't. I don't review the current review of systems compared to the prior one, because most of the time I don't expect it to change. I will look at, when I really scrutinize review of systems, is if I haven't seen a patient in a while or they're brand new to me. That's usually when I'm scrutinizing it, and I will ask them the question. As a provider, I will usually ask, is there anything else that's new going on since we last saw you? And then if that information is already in the chart, excellent. But I hope that answers that question.
I think so. Another question, our system typically generates specific questions based off of choosing from a list of complaints that we typically see, i.e. blurriness, redness, itching, dry eye, diabetes, etc. For yearly routine visits, is it necessary at each visit to put blurriness for patients that wear and have worn glasses or contact lenses for multiple visits, or even more specifically necessary for insurance reasons?
If it is an ongoing problem that has not resolved, if they have chronic blurring, or if they're just one of those patients that is always blurry, I think it's important to continue documenting. I'm not familiar, obviously we're probably not on the same system, but I think I have an idea where the question was headed, as in, they have to click blurry because the patient said blurry, and then there's a list of additional symptoms or things that they need to flush out. Jamie, can you distill down exactly what I can answer for that person?
Yes. So I think the main question would be, is it necessary to put blurriness for patients that wear and have worn glasses or contact lenses for multiple visits, which I think you answered, and then, or even more specifically, necessary for insurance reasons. So what I think I found really helpful as a tech was knowing the necessary verbiage in the chief complaint to allow the visit to be billable at what we're looking to bill it for. So at what level? If that makes sense.
That makes sense. So you're right. If it is a new problem, we usually bill it differently than a routine follow-up. And in routine follow-up, it would not be as necessary to put blurry there. But I would, the rule is more information is better in the medical chart. You really just don't want to, leave something that's critical out of there. I'm having trouble knowing exactly how to answer that question. I guess, Jamie.
And I think you've answered it.
Okay.
And, I think that the chief complaint is like such an art form that you're like asking just tons of leading questions. Explain more to me. Just as much information as you can give the doctor.
Yeah, and the most important things are, the chief complaint, why is the patient here, and then the HPI, right? And filling out as much of that detail as you can. I'm going to keep moving because I've got a variety of other things to show here. I'm going to just show you a relevant case for why history is important, okay? Just to keep things moving and a little interesting. So this patient's a 32-year-old nurse, came in reporting seeing something moving under his eye, okay? He says that he thought it was a worm, okay? That's strange. Okay, so if we stopped listening there, right, the exam shows that the eye is a little red, nothing remarkable, certainly no worm, the vision is fine, et cetera, et cetera. But it is a little strange. We send him home, and we probably wouldn't hear from him again. But there's more to the story for this patient. He's from Cameroon, and he moved here 5 years prior. There's an idea, or there's an example of why social history is kind of important, right? Because in Cameroon, there happens to be a large prevalence of something called loa loa, or the African eyeworm. So maybe his complaint of seeing a worm under his eye is not that outrageous. This is a sample from that patient's blood with a tiny worm in it. So while we didn't find the worm in the eye itself, we believed his story, drew his blood, and looked for the worms in the blood. We were able to find it there. So sometimes it is worth fully vetting a patient's complaint, even if you think it might be a little crazy. So I'm going to move into the pupillary assessment unless there are any additional questions about history taking.
There is a question, not necessarily about history taking, but about compliance with ocular medications.
Okay.
What about non-compliant patients with ocular medications? At what point would you do something more than just drops? For example, surgery?
Well, that's a great question. And it's fairly involved, but from my perspective, if a patient is getting worse, and I'm assuming we're talking about glaucoma, but it could be a variety of things, infections, et cetera. If the patient's problem is progressing to the point where it could lead to permanent vision loss, whether that's progressive visual field loss in glaucoma or uncontrolled pressure, or an infection that is not resolving because the patient is not using their medications, that's usually when I proceed to surgery. I think to expand just a little bit more, because I'm a glaucoma specialist, we have been inching towards earlier surgical and laser intervention in glaucoma for that very reason, right? I don't have to tell anybody on this call, but the number of patients who are 100% compliant with their drops is far from 100%. In fact, we're lucky if we can get patients to use their drops 60% of the time in some reports. So it's a very, very valid question, and one that's, I think, is actually relevant to what we're talking about today. It's really important to establish the best rapport you can with a patient to understand whether or not they're using their drop and report it to your doctor. It has not happened infrequently that one of my techs can elicit that a patient is not using their drops as we had prescribed. And that's probably not something that I would have obtained myself. So I think it is really, really powerful to make sure that you are building a relationship to get that sort of information that they don't always offer up right away. So good question. Okay, I'll move on to the pupillary assessment. This gets complex, but I think it's worth going over because I think it's really important to understand what you're doing when you shine a light in somebody's eye. And as technicians, you'll always be doing this, right? And it's really important. Here's why. The basic principle of the pupillary path is that light shining in one eye should affect both pupils, okay? And here's the gist of it. A light source is used to observe pupillary response in the eye that's being shined in and the light in the fellow eye, and also accommodation. So we want to understand how the pupils react to both light and accommodation. Of course, accommodation being the ability to zoom in up close. So what do the pupils do when they're looking in the distance compared to what the pupils are doing when they're having to focus at a near object? We're trying to both get this qualitatively, does the pupil react at all? And quantitatively, how much does it react? And if I remember correctly, I think I created a little video here. So light enters the eye. Okay, we're gonna have to see that one again. Okay, so light enters on the eye on the right, travels down the pathway to the brain, splits off to both sides of the brain, and sends a signal back out to both pupils. That's how it works. I'll give you one more look at it. This is why light going through one eye causes a pupillary reaction to both, okay? And this is one of the main principles you need to understand when we're talking about the pupillary exam. Light in one eye creates the same reaction in both eyes as long as the eyes and the system is working appropriately. Again, the light shining in either eye, either the left or the right, creates the same response in both eyes. In response to light, a normal pupil constricts, okay? Accommodation causes the pupil to respond as well. This is what we're measuring. We want to make sure that the pupils constrict when they are focusing at near as compared to a distance. So to put it simply, the pupils should respond similarly to light and accommodation. Some things cause a difference in ability for the pupils to respond to light versus accommodation. To give you one example, the classic example in medical school is syphilis. Didn't think I'd be talking about that today. Syphilis causes pupils that can accommodate, but they don't react to light. So if you have somebody whose pupils don't respond to light, but they accommodate, that's called light near dissociation, and it is a possible sign of syphilis. Not that I would expect you guys to be suggesting that to your doctors. In fact, please don't tell them that you learned that from me. Okay, a normal pupillary exam. These are the things that we document. We want to, one of the easy ways to document that pupils are normal are that the pupils are equal, round, and reactive to light and accommodation. So they're saying they're the same size, they're both round, they're reacting to both light and accommodation. So we've got PERRLA. A lot of times the way we document that, if you haven't seen it already, is PERLA, right? And that's a common way to document that the pupillary exam is normal. Another way to do it is to call out what is abnormal about it. So some terms here that we'll kind of dive deeper into. Anisocoria is that the pupils do not match in their size, okay? A non-reactive pupil is a pupil that does not react to light. And then an APD, or an afferent pupillary defect, is that the pupils respond differently when you're shining the light in each eye, okay? And I'm gonna pause here before I dig further into each of these things to answer any questions that might have come up.
The one and only question thus far is, if pupils are unequal, does that affect vision?
Great question. Not necessarily. We're going to dig further into that, okay? So anisocoria. Literally, the pupils are different sizes. This is as it pertains to that last question. It can be normal, okay? But the amount of difference is where we start to draw the difference between normal and abnormal. Normal difference in pupil size is usually within 1 millimeter or 2 of each other. These two pupils are vastly different. This is never, ever normal, okay? Now, this is not exactly what the question was asking. The question was, is the vision abnormal if the pupils are different sizes? And the answer to that is no. It doesn't necessarily relate. It can, but it is not a 100% sensitive sign for visual abnormality. So it's also important when you have pupils of different sizes to document what affects the pupil size. Does light make it constrict? So if we saw this patient and had a light shining into that left dilated pupil and we see it constrict, we would want to document the left pupil is dilated but constricts to light, right? So we want to know, or the left pupil is dilated and constricts to accommodation but not light. That's something that's also important for us to understand. We measure pupil sizes. This is one of the quantitative things that we're looking for. And we can do so using a variety of things, including a pupil gauge, right? You hold one of these cards up next to the patient's eye and estimate it based on the size of the pupil, comparing to the size of one of these little circles. We can also measure it using a tool that actually outlines it and gives you an exact measurement, such as in the scan on the right. We can measure pupil size in both light and dark environments. And it's important in certain scenarios because pupils usually respond to light. We want to know what size is the pupil in dark conditions and what size is the pupil in light conditions. And in light, it's called a photopic pupil size. And in dark conditions, it's called a scotopic pupil size. So what can a difference in pupil size mean, right? Now, like I said, it can be normal. We call that physiologic. And like I said, it's usually a small amount of difference between the eyes. It could be pharmacologic. That means a drug is causing the difference. Certain medications that we use, things like atropine, if you see pediatric patients, sometimes they're on atropine. That can cause a pupil dilation in one eye and not the other, which can be a pharmacologic problem causing the difference in pupil size. A Horner syndrome can also cause pupillary size abnormality. 80s pupil, we won't dig into that as much, but also another cause. Cranial nerve 3 palsy is a scary possibility related to pupil size. And migraine, believe it or not, migraine can even cause a difference in the pupil sizes. We're going to dig into a couple of those. Jamie, are there any questions right now that I can answer?
I'm so glad you stopped. This is perfect. They're wondering if anisocoria can also be related to a brain tumor.
Yes. In short, yes, it can, but it not always is, okay? So there are a variety of causes for difference in pupil sizes, okay? Sometimes that's just the way somebody's pupils are. One of the things that's really important is if the patient knows about it. If they know about their pupil abnormality, most of the time it's not something bad, right? But if it's new or they just found out about it, etc., or they weren't aware of it, those are usually the cases that scare us. That's a really good question. So let's dig into a few of these causes. Hopefully answer some more of these questions. What drugs do we know of that can affect pupil sizes? A variety of drugs can cause pupil dilation. We use some of these in our clinics every day. Others we don't, like ecstasy and cocaine. These are things that can make the pupils appear large, right? On the inside, there are also medications that shrink the pupil, things like opiates. Some glaucoma medications like brimonidine and pilocarpine can cause the pupils to be smaller than they otherwise would be. Horner syndrome is a really interesting condition. I'm going to walk through a bit of this to really explain it, and this helps us understand the pupillary pathway a little bit better, but it is not 100% necessary to memorize. In fact, there are many medical doctors that don't fully remember or understand this condition. There are two muscles that cause a pupil to move. The inner one is called a sphincter, and it causes the pupil to shrink. The outer one is called a dilator, and it causes the pupil to dilate. A normal pupillary response activates the dilator muscle in low lighting conditions, and the pupil dilates. Okay, This is also what happens when you dilate a pupil in the office. Now, if you activate the sphincter muscle, the pupil gets smaller, right? That's what happens when you use things like pilocarpine, right? But when in Horner syndrome, one of those signals is interrupted, and it's interrupted to the dilator muscle, okay? So as you imagine, if you block that signal to the dilator muscle, what happens? The pupil constricts on that side of the problem, and it causes the pupil to be smaller than the other side, as you can see in this example here. That's a Horner syndrome, and where not the big pupil is not the problem side, it's actually the small pupil side. And what happens in Horner syndrome essentially is that it is not the light traveling to the brain that gets interrupted. It's the brain signal traveling back to the eye that gets interrupted on the side of the problem. The same thing happens here in a cranial nerve 3 palsy, but in a different way, and I'll explain that. The third cranial nerve is what sends the signals to both move the eye as well as to allow the pupil to move in response to light. A cranial nerve 3 palsy is what can cause a dilated pupil as it interrupts the signals to constrict the pupil. Okay, and this is where a dilated pupil is the problem. Okay, so Horner syndrome, the small pupil is the problem. In cranial nerve 3 palsy, the large pupil is the problem. And most of the time, you're going to have other signs. As I said, that nerve is sending signals for the eye to move as well. And so most of the time, there's a strabismus or disconjugate gaze created when that nerve is interrupted, as well as a large pupil size. The question is, do you have to have a pupil abnormality in a cranial nerve 3 palsy? And the answer is no. Somebody had asked the question, can you have a pupil abnormality in a brain tumor? Yes. Here's how. This brain tumor can push on the optic or on the cranial nerve 3 and interrupt those signals to the eye, such that the eye movement and the pupillary response are impaired. So the answer is no. And I'm going to pause here before moving on to the non-reactive pupil and answer any questions that have come up.
Just one question thus far, and it's a really good one. If a patient calls into the office and says one of their pupils is a different size, how soon should we see them?
Great question. That's when the triage starts, and the knowledge of what can cause that is really important. Usually what I would do is say, is this the first time you've noticed it? How did you notice it? Did they notice it while they were putting on their makeup and they look at their pupils every day and today is just blatantly different? I would see that patient that day because it's relatively acute and not, can you guys hear that? The car alarm that's going off in the back here? I don't know if it's translating, but I'm going to keep talking and hopefully it doesn't. Okay, now it's gone. Sorry about that. Hope it wasn't my car. The urgency with which to see a patient with a pupillary abnormality largely has to do also on the other signs and symptoms. Are they having vision trouble, headaches? Double vision is probably the main thing I'd want to know about immediately, right? Because double vision, as you can see in this diagram on this slide, would likely be present if a pupillary problem is related to a tumor or something scary, right? Because that tumor is going to cause additional symptoms, not just the pupil problem. And so most of the time I would see a pupil problem as long as it is not something anybody had ever noticed before. I would probably see them that day. Now, most of the time the exam will be normal and it'll be incidental finding, right? Or be something innocuous that is not going to cause, bodily harm to the patient. But it is something that can be scary, can be dangerous. And so I would err on the side of seeing the patient sooner rather than later if there was a true pupillary abnormality. So let's talk a little bit about a non-reactive pupil. This is a pupil that does not respond to the light, okay? Now, we've already talked about medications that can cause that. We all use them every day to dilate patients. We know that after we do that, those pupils don't respond to the light. Trauma can cause this as well. Surgery, if they've had surgery of any sort on the eye, That can cause pupillary problems. And then, of course, the cranial nerve 3 palsy, those pupils are not going to react to light. The difference between a cranial nerve palsy and anisocoria is anisocoria, those pupils will both respond to light normally. There'll just be different sizes in the light and the dark. Cranial nerve 3 palsies will not respond to light, or they'll be grossly different between the two eyes. I want to spend some time on afferent pupillary defect. This is really important because this is the most visually relevant pupillary abnormality, okay? It's also called a relative afferent pupillary defect, or RAPD. This is not as much about signals coming back to the eye from the brain. This is about the signal going from the eye to the brain, okay? Afferent means traveling to the brain. That's how you can remember this one. Efferent means traveling from the brain. So what is an APD? It's when more light is getting to the brain from one of the eyes than the other. I'm going to say that again. An APD is when more light is getting to the brain from one eye than the other. So is vision more likely to be poor with anisocoria or an APD? An APD means less light getting to the brain. Therefore, it's more likely that the patient has vision trouble from this. Anisocoria just means that the pupils are different sizes and does not mean anything about the light that's getting to the brain. So let's talk about pupil size and APD. Here's the classic conversation. When there is an APD, does there have to be anisocoria, or can the pupils be the same size? The pupils can be the same size, bro, but can there be anisocoria and an APD at the same time? You bet. You're a genius. Well, I did figure out how to make this fake text message online. So here's how we figure out whether or not there's an APD. A normal pupillary response without an APD. You got both pupils are the same size. You push the light to the left side. Both pupils constrict the same way. You swing the light over to the other side. Both pupils constrict equally. That's a normal pupillary exam. Now an APD, okay, both pupils here are the same size, okay? Now there's no anisocoria, both pupils are symmetric, but the response is different. In the left eye, both pupils constrict the same way. Again, this problem is not about the ability for pupils to constrict, so there's going to be symmetry between those. But when you swing it to the other side, there's symmetry here, but there's relative dilation compared to the one before, okay? Smaller, larger. I hope that, I know it's subtle, but there's this diagram was the best one I could find. This pupil and this pupil is larger than this pupil and this pupil. That means that not as much light is getting in through this eye as it is then through this eye. So which I've given that answer away. Remember, the abnormality is the light going to the brain. This eye is not transmitting the same amount of light as this eye. And I hope that makes sense. This eye, the brain is perceiving less light, so the pupils dilate a little bit compared to the more light the brain is perceiving when it's shining into the left. Here's the best RAPD explanation that I have.
Hi, today we're looking at relative afferent pupil defects, or RAPD.
I'm going to zoom forward here in the interest of time because they're talking about accommodation and movement here.
With the lights off. Here, the normal pupils constrict briskly, then relax a little. They dilate again after the light is removed. Now swing the light from eye to eye quickly, but pausing on each eye for around 2 seconds. In the normal patient, the pupils will constrict, then relax a little each time the light is swung to them. Now a patient with a relative afferent defect. The pupils will be equal in size in both light and dark. Both pupils will react to light, although sometimes a slower response is noted when light is shone on the affected side. With the swinging light test, the RAPD now becomes obvious. On the affected side, both pupils dilate when the light is swung across. Here, the left side is affected. You will miss an RAPD if you do not do the swinging light test, as it is only by comparing the relative strengths of the signals reaching the brain from the eyes that the abnormality is detected. Finally, with a complete.
Jamie, did that audio come through, or did everybody just watch a video in silence?
No, we heard it.
Great. Okay, I can answer any questions here as well.
The only question is, with an APD, do you ever see only one eye dilate?
With an APD, do you ever see only one eye dilate? If the APD is the only problem, the answer is no. The dilation of the pupils is not directly related to whether or not there's an APD. In an APD, the abnormality is with the optic nerve or the tract leading signals to the brain, not controlling the pupillary muscles. So most of the time with an APD, the pupils will dilate just normally when you put drops in, and I believe that's probably the question. So it's not as much about the ability of the pupil to react, it's about how much light is getting into the brain. So on this slide, the pathology of an APD is somewhere along the pathway from the eye to the brain, okay? Okay, let's talk a little bit about causes of an APD. In the eye, a large retinal detachment can limit how much light that eye is sending to the brain. Similarly, a central retinal artery occlusion or a stroke of the retina can do the same thing. End-stage glaucoma also limits how much light is being sent to the brain. All of these can cause an APD. In the optic nerve, optic neuritis, sometimes thought of as, the visual component of multiple sclerosis, can be related. That can cause an APD. A tumor, as we had seen, can cause an APD if it's pressing on the optic nerve. Again, the tumor I'm referring to here is not one that is pressing on this nerve. It is one that's pressing on this nerve, okay? An ischemic optic neuropathy or a stroke of the optic nerve can cause an APD. So as you might imagine, this is probably one of the more common causes of an APD, is ischemic optic neuropathy, especially if it happens suddenly, as opposed to end-stage glaucoma. So here's a little bit of summary, and then we can take some additional questions with any time that's remaining. The history taking can be really, really important. I mentioned this earlier, but I believe it. If you listen carefully, the patients will tell you what's going on with them, right? They'll tell you as you ask open-ended questions, and if they're not giving you answers that you need from the open-ended questions, you can ask directed questions like, tell me about when you're noticing trouble with your vision, or tell me about how your eyes feel throughout the course of the day. And then the pupillary exam involves closely comparing size and reactivity of the right and left pupils. And I'm hoping that it's clear the difference between anisocoria and an APD. Just to summarize, anisocoria is simply the difference in pupil size. It can be normal. An APD is never normal, and it has to do with the reaction of pupils to light and comparing the two. You can have anisocoria with an APD. You can have an APD with anisocoria, but neither is a must. So it's important to note that there are significant but different problems of the eye. Jamie, I can take additional questions now as well.
So far, one just popped up. Is an APD something that can go away, or will it always be there?
It depends on the cause. In optic neuritis, where you get inflammation of the optic nerve, we often see a reversal of the APD. In things like ischemic optic neuropathy, that's usually not something that we would expect the APD to resolve with. Again, when we have confirmed an APD and there is a known cause, a lot of times those patients are followed by somebody who specializes in neuro-ophthalmology, and you can actually quantify an APD to follow it. Very briefly, here's how you do it. and I don't do this here in my office, but you can use things called neutral density filters that can actually take a flashlight and you hold the filter in front of the good eye to approximate how much you have to decrease the light going into that good eye to approximate the other eye, and it actually gives you a value on how much less light is getting into one eye than the other. That's not something you need to know. Just know that you can quantify it. We can follow it. And sometimes it does get better in certain cases. But in a lot of cases, I wouldn't expect it to go away.
Another question is, can you ever have an APD with documented good vision in both eyes?
You can. You can have an APD with documented good vision in both eyes. I have seen that before. Here's the scenario. Let's say you have a large amount of ischemia of the peripheral retina. Okay, and it's limiting how much light signal can get to the brain, but the macula is spared, and you have a central island of vision. Okay, you can still have decent vision, but yet, as measured on a central visual acuity chart like Snellen, but have an APD. It's unlikely, but it's possible, okay? It's not as possible as it is anisocoria remaining, having good vision. So APD is a really good sign. If somebody, let's use a case example. Let's say somebody comes in complaining they can't see anything. Okay, there's no light getting into one eye. An APD is a way to validate that, right? They've got profound vision loss. If there's an APD, it's likely that there is actually an organic cause for this. If there is no APD and they're saying their left eye is not seeing any light, I would be highly suspicious of functional vision loss or some other type of thing going on with that patient. What else, Jamie?
So far, no. Oh, another one here. With anisocoria, is that something that develops over time?
It depends on the cause. It can. A lot of times anisocoria is sudden. It's not something that develops slowly, and it's sudden related to some sort of cause, whether it's trauma or surgery. There are conditions that it just spontaneously happens in, something like the 80s tonic pupil, which is not visually significant, and we didn't go into depth here, but I think that it is something that would kind of just show up sometimes, and usually that's in middle-aged females. We see more commonly with that, but it can happen in anybody. But if it is a true and significant anisocoria, it's usually more of a sudden onset. I would not expect it to gradually develop over time. What else?
You have answered all the questions thus far.
Should we give them a few minutes to think of some more, or do you think they're tired of me now?
I think you're good to go, Dr. Bartman. Thank you so much.
Well, I really, really appreciate everybody sticking with me. If you are still listening out there and I didn't bore you to death, these are tough subjects, but I think they're really important and they're complex, right? And so they take some time to digest. It would not be unanticipated if you're sitting here now thinking, gosh, I still don't really know anisocoria and APD. It takes some thinking to digest, right? There's no way that you can learn it in just an hour-long session to be an expert in it. And I don't think that you need to be. But as long as you know the difference generally and what you are testing, if you are implementing these tests in your office, knowing a little bit about, hey, wait a second, when I shine a light in an eye, I'd expect the other eye to react the same way. Then you're understanding a little bit more about the principle and why we're testing.
All right. Thank you so much, Dr. Bartman. I'm just going to have a couple closing remarks here. If you are seeking the credits, please complete this session's quiz by Friday. If you signed into the chat and participated with questions in the Q&A, the link has been emailed to you.